Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, Precision Medicine, the Pathway to Precise, facilitated by Dr. Bynum and moderated by Adam Hill. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. These include support groups led by licensed mental health professionals, stress reduction classes like yoga and Tai Chi, a monthly nutrition seminar facilitated by Kristen Kukolowski, an oncology dietitian with Northside Hospital Cancer Institute, and education programs like these. And if you ever miss a live event, we invite you to visit the video tab of our website, cscatlanta.org, where you can find recordings of all past events. I'm excited to welcome today's program moderator, Adam Hill. Adam graduated from the University of Mississippi School of Pharmacy and completed his practice residency with Northside Hospital. He served as the inpatient clinical pharmacy specialist in medical oncology at the Atlanta campus of Northside Hospital. Adam most recently worked with an interdisciplinary team to develop an oncology precision program, Cancer Genomics Team, at Northside Hospital Cancer Institute. He's a member of the Hematology Oncology Pharmacy Association, Georgia Society of Clinical Oncology, Atlanta Academy of Institutional Pharmacy, and Georgia Society of Health System Pharmacists. So with that, welcome, Adam. We are happy to have you, and I'm going to pass it off to you to begin today's presentation.
Great, Katie. Thank you, and welcome everyone to this Cancer Support Community program today. It's going to be very exciting for our program titled Precision Medicine, the Pathway to Precise. I'm very honored to moderate this program and introduce our presenter today, Dr. Jennifer Bynum. Dr. Bynum is a board-certified pathologist at Northside Hospital in Atlanta, Georgia. She earned her MD from the University of Alabama at Birmingham in 2013, and in 2019, she completed residency in anatomic and clinical pathology, a hematopathology fellowship, and a molecular pathology fellowship at the Johns Hopkins University in Baltimore, Maryland. During her training, she was involved in refining, processing, and reporting practices for large next-generation sequencing gene panels to improve their functionality and clarity for her clinical colleagues. And at Northside, she is a part of a multidisciplinary molecular tumor board. As a part of the National Association of Molecular Pathology, she is the hematopathology representative to the Training and Education Committee, with a particular focus on education surrounding emerging and evolving biomarkers. So again, I'm very honored to present Dr. Bynum, and I will let her take it away from here. Dr. Bynum.
Well, hello, everyone. It is my absolute pleasure to be able to speak with you today on my favorite subject, which is precision medicine. And I'm really just going to be talking you through the pathway from person to a very precise diagnosis. But before I get too far, I just want to sort of explain who I am and give you a better understanding of how I play a part in the cancer process, as if I do my job well, you really shouldn't ever meet me. So first definition is pathology, and pathology is very simply and broadly defined as the study of disease. And of course, it follows that a pathologist is a person who studies disease, and that is who I am. There are many different types of pathologists who study many different types of diseases. But broadly, we all sort of hide in the basement of the hospital. And in fact, many people think that we live in the dungeons. I assure you that although we are in the basement and don't have any windows in our offices, it is 70 degrees and fluorescent 100% of the time. And we welcome visitors anytime anyone has a question or wants to touch base with us. One good way to think about how pathology works is to think of us as an answer box. So what happens is clinicians see a patient and have a question about what's going on, and they sort of put their question in the form of some sort of sample into the box, which is pathology. And again, if we're doing our job right, an answer should pop out the other side of that. As someone who works in the lab, we usually think about things in this way, before the lab, and after the lab. The sort of fancier terminology that we sometimes use is before the lab is the pre-analytical phase of things, the lab is the analytical phase of things, and after the lab is the post-analytical phase of things. And we're going to talk a little bit about each of those pieces of the process. Now, obviously, since I am pathology and I study disease, the majority of my time is in the lab, and the majority of this talk will be focused in the lab, with Dr. Bordoni spending a bit more time in the before and the after. But I will touch a little bit on both of those. So the before the lab part, we'll talk about getting from symptoms or whatever it is a patient is experiencing to a sample that we would receive in the lab. In the lab part, we'll go from getting a sample to a cancer diagnosis. And then, of course, the main part of this talk, getting from a cancer diagnosis to a molecular or a more precise diagnosis. And then the after part of the lab will be getting from a molecular diagnosis to maybe what the next steps would be from that diagnosis. And then we'll back up a little bit into the lab again to talk about the implications for your family. So beginning with the before, getting from symptoms to a sample. And I put this picture up just to sort of demonstrate that there are many different pathways to get to the lab. And the sort of endpoint that we're talking about in getting to the lab today is the part of the question that is this cancer or is this not? But you'll see that even sometimes the pathways to the lab involve the lab. So if you think about how we get to the point of needing a sample, perhaps a patient would come into the emergency department with a terrible, intractable, upset stomach, nausea, vomiting, weight loss. In the emergency department, a patient gets a CT scan and a mass is found. That might be one way to get to us. Perhaps a patient comes in to the primary care doctor, complaining of being so tired they can't stand it, maybe having night sweats, maybe having fevers. Patient gets a blood test. There you see the lab and the path to the lab, and some sort of abnormal lab result comes back that suggests, oh no, maybe this patient actually has cancer. Or maybe a patient comes in with no issues at all and just for routine screening, like a mammogram or a colonoscopy or something like that, and a lesion is identified. The one thing that all of these sort of pathways have in common is that at some point, we're going to get tissue or a sample. Now, I'm going to use the term tissue in this talk very broadly. Tissue could be skin, liver, piece of stomach, could be blood, could be urine. There are a lot of different ways for us to look for tumor. But again, I'm just going to very broadly use the word tissue with an understanding that that can mean a lot of different things. So whatever it is that is coming to the lab, we need some sort of tissue to begin the process. So I'm going to go ahead and move on to the lab piece of this, again, the largest part of the talk, and we're going to discuss getting from a sample to a cancer diagnosis. So what we most often receive in the lab is a container with a patient's name, date of birth, all their information, and something in it. Perhaps it's coming from the OR, the operating room, if you have an invasive biopsy or a large lesion resected. And someone literally just takes that tissue in a bag, walks it across the hallway to the lab, and we accession it, we assign it to the right person, to the right date of birth, and that container is then taken to a pathology assistant most often. And that pathology assistant is a very highly trained individual who then examines the sample and takes pieces of the sample for the next steps in processing. Now, a pathology assistant has to have a really good understanding of how tumors work, because what they're going to do is they're going to take that piece of tissue out of the container and they're going to describe what they see. They're going to describe any lesion. They're going to describe maybe how close it is to margins, maybe how big it is, what it looks like, etc. And then they're going to take tiny little pieces and put the tissue into cassettes. So these cassettes probably look oddly large on your screen. In reality, they're only a couple of centimeters in length and maybe half a centimeter in depth. And the pathology assistant has to take pieces that represent the lesion and how far that lesion is to margins and other important parameters, and represent that in little tiny pieces for the pathologist down the road. So the pathology assistant is going to fill up one or sometimes many cassettes, depending on what the tissue sample looks like. And then when they're done with that cassette, they're going to put it into a processor that basically takes the tissue and embeds it in paraffin. And paraffin is this very sort of hard, thick, waxy substance. And the reason that they do that is because putting the tissue into something that's very hard allows us to cut it into very thin sections. This is a microtome, and this is where sort of the next person comes into play. Usually a histotechnologist does the cutting. And if you'll notice in the block that's being cut, you can see that the tissue is still red. Much of the tissue in your body is red, and so that is a color that we would expect to see there. But then as you cut those really thin sections, you can sort of make out the outline of the tissue embedded in that paraffin, and you can see that it is clear. Now, if we were to take a glass slide and just set it down on one of those sections, then it would adhere to the slide. And if we looked at it under a microscope at that point, we really wouldn't see much because it's all clear and it's cut so thinly that we're basically looking at a single or just a few cells in thickness. So the next thing that happens is that the histotechnologist cuts these pieces, adheres them to slides, and then we have to stain those slides. There are many different ways that we in pathology can stain slides. The most common type of staining that we use is hematoxylin and eosin staining, which basically is a fancy way of saying we make the cells all look pink and purple. Again, there are many different types of stains that we use, but this is usually where we start. And this is an automatic stainer that basically takes the slides that have that really thin cut tissue on them, and it dips them in various substances. So it dips them in one substance, and then it sort of washes that off, and then into the next substance and washes that off, etc., until we have beautiful pink and purple slides that we can look at under the microscope and see really great cellular detail. And ultimately, those slides land on the desk of a pathologist, and the pathologist looks through a microscope and decides whether there's cancer there or not, and describes it. Now, I share this picture because I just want to be very clear that we in pathology, although we don't always take ourselves terribly seriously, I do assure you that we always take your disease and your diagnoses very seriously. And ultimately, we put out a report from pathology. I just sort of pulled a sample report here. You can see this is the patient's name is last name, first name. This is not a real person, but just to show some of the things that we pull out from that initial tissue, just from the simple cutting, embedding, staining, looking at under the scope, we can often say a lot. So usually in our reports, we'll include whatever clinical history the clinician has provided for us. In this case, you can see it's a large gastric mass. The specimen, whatever it is that we received. In this case, the pathologist received gastric mucosa, or sort of the inside lining of the stomach, and then we'll give a diagnosis. So we say what the specimen is, stomach. We say what the operation was. In this case, it was a partial gastrectomy. In other words, they took out part of the stomach. And then we'll describe what the tumor type is based on what we see on the slides. In this case, they're describing a malignant epithelial gastrointestinal stromal tumor. That's usually the first thing that we'll say is what the tumor type is. And then we go on to give whatever descriptors are important for that particular tumor. In this case, size is important. What the cells look like is important. The cellularity is important. We might talk about how fast it proliferates. We might talk about the margins. There are a lot of different parameters that we look at and describe depending on the tumor type. And this is sort of the starting place for your treatment. So if you think about what sort of what's happened so far is we've come in with symptoms, or for screening, somebody has, had a light bulb that went, oh no, there may be cancer here. Some sort of procedure has happened, whether it be a biopsy or a blood draw, or, what we're talking about here, this tissue diagnosis, that could be a biopsy or a bigger surgery. That tissue has come to pathology. We've gone through all of these steps of processing. Someone has looked at it under a microscope and said, yes, there is cancer here. This is the cancer type. This is how bad it is at this point. And with many tumor types, that's enough to get started with treatment. That's really all your oncologist needs to know to move on to the next steps. Now, your oncologist may need other laboratory tests, like what do your blood counts look like, or they may have some sort of marker for your tumor that they're wanting to follow to sort of get an idea of what the volume of your tumor is, et cetera. But often from here, there's a very standard way that we treat something. Now, in some cases, when someone presents with a very advanced tumor in the beginning, or maybe has already failed other lines of treatment, they're going to move on to needing more information. So that is where we go from our cancer diagnosis to a more precise diagnosis. Now, here I'm going to pause one more time because I think that you need a few more definitions before we get into the real nitty-gritty stuff. So I've already talked about the answer box, right? So the question for the clinician goes in, some sort of magic happens in that box, and an answer pops out. I just want to be very clear that there are a lot of types of tests and a lot of things that happen in that box. I talked about one pathway from piece of tissue to what we're seeing on the slide. But remember that blood can go in, that urine could go in, that many tissue types can go in, that many different types of tests can be done on each of those things. And there are many different people sort of with their hands in those pots. So I'm going to talk about a few very specific things, but do understand that there's a whole army of people in that box doing often very complicated and very important things. So two important vocabulary words, starting with precision medicine. This is a newish term, and one that a lot of hospitals like to use because it sounds cool and important, and it is cool and important, but the concept of precision medicine really isn't new. An example of this is a blood transfusion. So we've been giving blood transfusions to patients for a long time, and when we give a blood transfusion, we don't just pick any unit of blood off the shelf and give it to any patient. Instead, we pick blood with certain phenotypes to give to a certain patient, right? You give A positive blood to an A positive patient. So if you think about what precision medicine really means, the idea is that the medicine or the treatment that's being offered is really geared toward an individual. We gear treatment toward an individual in blood banking, and we do this in many, many other ways in medicine. Another important term here that we're going to use here is biomarker testing. So biomarkers can be many different things. They can be genes, they can be proteins, they can be other substances, but the idea of a biomarker is something that we can look at, that we can follow, that's maybe unique to your tumor or unique to your tumor type. So an example is PSA, or prostate-specific antigen, which is something that we often follow in folks with prostate cancer. And the reason that we do that is that often, well, in a normal individual, it should be low. And if it's high, that makes us go, well, maybe there could be cancer there. And so then we're going to move on to our biopsy. And then maybe we find that a patient does have prostate cancer. And so we examine it, we make that diagnosis, maybe the prostate is taken out, then that PSA level should go back down to 0 or close to it. And if it bumps back up again, then we think, oh gosh, well, maybe that cancer is growing somewhere else. So it's nice for us to have biomarkers, whether it be a gene or a protein or something else, that we can follow to get an idea of whether something is going right or going wrong without doing any invasive procedures. And much of precision medicine is finding appropriate biomarkers for a person's tumor type. Now, another really important thing for us to understand as we go through this is a person versus a person's cancer. This may seem very basic on the surface, but it actually gets kind of complicated when we start talking about genes and DNA. So I'm going to talk about Bob, and I'm going to talk about Bob's cancer just to be able to blame cancer on an individual. And I want you to understand that the majority of what we're going to be talking about for now is Bob's cancer. And I'm going to back up and talk about Bob sort of as a whole person at the end. So I think that the important thing to understand here is that Bob's cancer is part of Bob. So if I look at the genes in Bob's cancer, I'm going to see Bob's genes, but I'm also going to see whatever sort of has gone wrong in Bob's genes to create the cancer. What is cancer? It's basically cells misbehaving, right? It's cells doing the wrong thing. And there are many, many different ways that cells can do the wrong thing. And a lot of the looking at genes or biomarker testing is figuring out what it is about the cancer that is different from the rest of Bob. So again, sort of the vocabulary that we use to describe this more formally is if we're testing Bob's cancer, we call that somatic testing. And if we are testing something in Bob that should be in all of Bob, we call it germline testing. And the reason that this is important is that changes that are only in Bob's cancer can't be passed on to Bob's family, but changes that are in all of Bob can impact Bob's family. So again, we're going to start by talking just about Bob's cancer and what's gone wrong to create it. And we'll back up and talk about the germline testing and the implications for the family. So getting from a cancer diagnosis to a more precise diagnosis. Most of the time we go back to tissue. So it's really nice if we already have a diagnosis from pathology, maybe we have the gastrointestinal stromal tumor or, whatever tumor type it is, we can just go right back to that paraffin block. We can take off a few more sections and we can send it for additional testing. Sometimes if we don't have tissue or if maybe it's been a while since there's been tissue, we may get a blood sample to test instead. But most often, we do one of those two things for a sample for additional testing. Now, I'm going to jump right in the deep end here and talk about next generation sequencing, which is one of the more complicated precision medicine tests that we do. And I'm going to start out by talking about this because we do a lot of this these days. Almost everybody with advanced or metastatic cancer is going to have a next generation sequencing panel somewhere at some time, and sometimes people get more than one of them. And this type of test can look at a lot of genes and a lot of changes all at one time. Now, I'm going to show you some kind of technical slides here, but I'm not going to get very technical. The first thing that I want to point out, and this goes for NGS or really any other type of testing, is that the first thing that we have to do is isolate what it is we want to test. So I told you that we, may go back to the tissue or we may get a blood sample, but we have to get, if we want to test, so in this case, DNA, then we have to pull the DNA out of whatever the sample it is, or whatever the sample is that we have. Now, again, I'm not going to get technical here, but we go through lots of fancy steps with chemicals and spinning things down and washing things, etc. But let's suffice it to say that at the end, we pulled the DNA out of that paraffin, or we pulled the DNA out of the blood. Or if we're testing RNA, we pull the RNA out. Or if we're testing protein, we've pulled the protein out. I'm going to talk for the purposes of this talk just about DNA to sort of keep it simple. So once we've gone through the steps of isolating what it is that we're trying to test, then we are going to start the process of actually testing it. And if any of you have had NGS testing before, or if you're a clinician and you have waited on NGS testing before, it takes a little bit of time. And it takes a little bit of time because there's a lot of pieces to the process. I've already talked about the first piece of the process here, extraction of the DNA. In NGS, generally what we do next is we do something called shearing, which is basically sort of breaking it apart so that we can get to it, right? DNA is a helix, and it's two strands that are attached to each other, and we want to break pieces of those apart so that we can use them. The next part is that we stick things to the DNA so that we can identify what we want to keep. And then we're going to purify it somehow. So in other words, we're going to try to get rid of all the things that are left that we don't want. We've already isolated the DNA, and now we've broken it apart. We've attached things to it so that we can identify the pieces that we want, and then we're going to get rid of all the pieces that we don't want. At that point, we want to amplify it, because our initial little bit of DNA is in fact a very little bit of DNA, and we want to have a lot of it to look at. And so we go through a process called polymerase chain reaction most often, or some variation thereof, that takes that little bit of DNA and turns it into a whole lot of DNA. And at that point, we sequence it. And I have here, there are many different types of sequencers. I have here one's called the NovaSeq. And this is a really cool instrument. Basically, what this lady in this picture is holding is, you can think of it kind of like a chip, and you put samples on it, and you can put multiple patients on the same sample. You've already identified it as that patient because of some of those things you attach to the DNA, and you stick it in the machine, and the machine sort of works this sequencing magic. The sequencing magic is actually very complicated and brilliant technology. But for the purposes of this talk, this chip goes in and the machine starts its work. And at that point, there is this, again, sort of magic of bioinformatics that happen. Now, I am not an expert in bioinformatics. Sometimes I have trouble figuring out which side of the computer is up, I confess. But this magic happens where all these little pieces of DNA that we've picked out that have now been multiplied are all lined up in the right place at the right time. And what you're seeing here is each little bar actually represents a little piece of DNA. So every little pink bar is a little piece of DNA. Every little blue bar is a piece of DNA. And bioinformatically, they've all been lined up so that we can look at them. Now, every lab does this a little bit differently. And some labs actually, well, actually probably most labs at this point, have a process by which the technology that's doing all this lining up will also, what we say sometimes is, make calls for us. In other words, the technology says, you know, this is what's supposed to be in this spot, but this is actually what's in this spot. And we'll pull it out as an abnormality for us. But even if the technology does that for us, there's usually a human element that goes back and looks at sort of this picture here and says, oh, well, you know, that's clearly an abnormality, check. Or they go, you know, the test didn't quite get enough reads in that. I'm not sure if that's real or not. There's a process of reviewing this and making sure that all the calls that the technology makes is correct. Now, once this part is done, at some point a report is created. And I pulled a Foundation report because we have someone from Foundation here today feeding us. But there are many different types of labs, and there are many different types of reports that are put out. And again, every lab is a little bit different. But in almost all of the reports, what you're going to have is a list of abnormalities. So you can see on the left-hand side, there's a list of genomic alterations detected, and they tell us what those are. And then some labs will give us treatment options, maybe FDA-approved treatment options for that cancer type, or maybe FDA-approved options for other cancer types that have that same abnormality. And some places, many places, will also give us options and ideas for clinical trials. Now, I will point out that this piece of paper is incredibly helpful to us as clinicians as we decide our next steps. But even if, you know, they tell us that, you know, X drug will work for X mutation, there's still a lot that we have to sort of sort through as to whether it's appropriate for the patient or not, right? So Foundation may tell us that X drug would be great to treat this mutation. However, we know that X drug is really hard on the kidneys, and this patient doesn't have great kidney function. So this is not going to work for that patient. So there's still sort of a process even after this report comes out that we have to go through. But this report gives us a great idea of what's going on, what's driving the cancer, what maybe we can treat, etc. Now, I'm not going to talk a lot about different types of tests, but I mentioned that in that answer box, there's a lot of different types of tests going on. And I just want to show you one other. There's a process called fluorescence in situ hybridization. We abbreviate this as FISH. I'll give you a minute to let that sink in. Fluorescence, F-N-I-S-H, right? FISH. And we sort of go back to the materials the same way that I described for next generation sequencing as far as getting a sample. And basically with FISH, what we do is we attach a probe directly to a chromosome, and it's kind of like a little glowworm. And what that probe does is it attaches to a certain place, and we look at it under the microscope, and well, under a special microscope, a fluorescent microscope, and we see what the pattern of signals is. So if you were astute, you can maybe look at these little blue dots on the right. I think there's 3 blue dots in that picture. And in each blue dot, there's other bright dots, pink and green. And it tells us something if those 2 dots are far apart or if they're right together, kind of making a yellow fusion signal. And so I just show you this to show you another type of precision medicine testing that can be very useful. All right, so that's the idea of getting from a cancer diagnosis to a more precise diagnosis. Again, I can say this all day long, but there are many, many different types of tests. But the idea is to see what your cancer has and to get a better idea of what we can do to target your cancer. So then the question comes, well, how do you use those abnormalities that you find? So there are really 3 ways that we use them, and one of them kind of backs us up in the talk a little bit to the sample to cancer part. But we can use these precision medicine tests for diagnosis, for prognosis, and for treatment decisions. So briefly for diagnosis, I'm a hematopathologist, and so I always sort of back up to the peripheral blood. This is a peripheral blood smear that you're looking at. It's what I would see under the microscope. What's happened here is that someone has taken a blood sample, and they've literally taken that blood, smeared it on a slide, stained it, put it under the microscope. Now, I can look at this peripheral blood sample, and I could say, gosh, that looks a lot like acute promyelocytic leukemia. But I cannot call it that for sure without FISH testing, because acute promyelocytic leukemia, which I'm going to abbreviate as APL, is defined by a specific translocation, which is picked up by FISH, a translocation 1517. And this particular type of tumor is treated in a very specific way. These patients can crash really fast when they're first diagnosed, but if you treat them appropriately, then they do great. The survival rate approaches 100%. The prognosis is very good. So catching this particular disease is incredibly important. So if we look under the microscope and we say, oh gosh, it looks like APL, then we shoot it out the door for FISH studies and do the stat, we need this answer now, and treatment proceeds accordingly from there. So here is an example. That is an example of using precision medicine for diagnosis. And I guess that also sort of pushes us over into treatment. Now, another way that we sometimes can use precision medicine type testing for diagnosis is when we have a really ugly tumor. So maybe someone has a tumor where they have metastatic disease all over their body, so we're not really sure where it's coming from. The cells are really, really ugly, and they're not really giving us any clues as to what organ it originated in. Sometimes we'll do big panels of maybe NGS, FISH, some combination of things to try to get a better idea of where the tumor is originating so that we know how to treat it better. And, often the additional precision medicine testing doesn't tell us for sure, but there are certain tumor types that tend to have certain mutations. So it can give us a better idea of what we're working with and just act as sort of a guidepost for us. So moving on to prognosis, I'm sort of backing up into heme land again here, but again, this is a peripheral blood smear, and this is an example of chronic lymphocytic leukemia. And we use FISH testing again regularly to evaluate patients with CLL, chronic lymphocytic leukemia, because there are certain abnormalities. For instance, in this case, deletion of 17p, which is a TP53 abnormality that portends a worse prognosis than some of the other abnormalities that we see. And so it tells us this patient is probably going to do worse. And again, it sort of kicks us over into treatment as well, because it makes us think, well, maybe we need to treat that patient more aggressively, and often we do if the patient can tolerate it. And then finally, for treatment purposes, precision medicine is incredibly important. And this is often what we spend the most time sort of consternating over is, okay, this patient has these abnormalities. What does that mean for treatment? Now, if you'll recall, when we first started, I mentioned sometimes you get that initial pathology report. Well, often you get that initial pathology report and your oncologist already knows what to do because there's a very standard way to treat, X disease in the beginning. But when things start to go bad, maybe the first line of treatment has failed, or again, you present with very widely metastatic and advanced disease, we may jump to this type of testing much more quickly. And here I just show you an example. This is a lung adenocarcinoma. Someone did an NGS, next generation sequencing on it, and maybe they find X mutation that tells us this would be a great drug to use, or X mutation that says this drug probably isn't going to work. And we can often pull a great deal of information about targeted therapy from NGS reports in that way, about what will work and what will not. And then finally, the question that is probably incredibly important to all of us is the question of what about my family? So we're going to go back to this vocabulary of somatic testing, which is really what we've been talking about, and germline testing. Now, there are types of genetic changes that can be passed on in families, and the types of precision medicine tests that we use to decide, what changes are in a tumor and what changes are in a person, what's in Bob's cancer, what's in Bob, are very similar, but sometimes the testing sources or methods may be a little bit different. And I'm going to talk about this using the example of BRCA, because that's something that we've probably all heard of, and we think about BRCA mutations as something that is passed on in families. So let's say that we send a tumor sample, not Bob, but Bob's tumor out for testing, and he comes back with a BRCA mutation. Well, that could mean that the BRCA mutation is only in his tumor, and it could mean that the BRCA mutation is in all of Bob. And that's a really important distinction for us to make. So often if we find that, if a patient hasn't already gone to genetic counseling, it's time for them to go. And the genetic counselor will help sort of sort out the answer to this question. And often that requires some additional testing. So instead of getting a sample from Bob's tumor, we need a sample from a part of Bob that is not involved by tumor. That may be blood, it may be skin. There are a lot of different ways that we can go about this. But let's say that we test Bob, non-tumor Bob, and he is BRCA positive. Well, if we test non-tumor Bob and he's BRCA positive, then that implies that he has a BRCA abnormality in all of the cells in his body. And that means that he can pass it on to his children. It also means that maybe one of his parents had the gene and had this abnormality and passed it to him. And if they did that, then maybe his brothers and sisters and cousins, and you can go pretty far out, but usually we keep it a little close. Siblings may also be at risk. So if we find that Bob, all of Bob, not just Bob's tumor, is BRCA positive, then his family members may also choose to be tested. And it's kind of nice when we go about it this way from a testing perspective, because we already know that Bob has this BRCA mutation and we know what his BRCA mutation is. So when we go to test his family members, we can look for that specific mutation and don't have to do these huge, crazy panels. We can just look for that one specific mutation to see if his family members have it as well. And importantly, if Bob does not have a BRCA mutation in all of his cells, then his family members really don't need to be tested. That's just something that happened in his tumor when his tumor went bad. And because it's only in his tumor, he can't pass that on to his children, and he didn't get that from his parents. And so that saves his family expensive testing. And so that sort of concludes what I had to talk about. We talked about getting from symptoms to a sample, the before the lab, and in the lab, going from a sample to a cancer diagnosis, and then sort of taking that to the next level to molecular diagnosis. Then what we do with that molecular diagnosis, and we also talked about how this applies to our families. And before I open it up for questions, I just want to pause on this slide for just a minute. So on the left-hand side is my brother. His name is Jamie, and I think that you can probably look at Jamie and see that maybe he has some special needs. So Jamie had Down syndrome, which is a genetic disorder, and his disease was my initial interest in the world of pathology and the world of genetics. And on the right is my father-in-law. He's holding my child, who is not a baby anymore. This is a very old picture. That baby is now 13. But this is my father-in-law, and he recently had a devastating cancer diagnosis. And I share this not to be too personal, but just to say, you know, we sort of live in these deep, dark dungeons of the lab and often don't talk to a lot of people outside of the lab, but do understand that many of us in medicine and all across medicine have very close and personal connections to what we do. Many of us entered into this world for very personal reasons. And so even if we never see you and you never see us, just know that there is a whole army of people in the basement of the hospital who care a lot about you. And I would venture to say that many of your clinicians have very personal connections as well. So I know medicine can be a tough thing to navigate. Cancer can be a tough thing to navigate, but you have a lot of people who care a lot about you and who are working really hard to make sure that you get the very best care. And with that, I'll open it up to questions.
Dr. Bynum, thank you so much for sharing such a great presentation and some of your personal story about what got you here today. I hope everybody enjoyed that as much as I did. So any questions, please send through the chat box. I know Katie might be receiving questions. I will just kind of lead this off and ask Dr. Bynum, how has this pathway to precise really changed over the last, I would say, 5 to 10 years? Do you see that what the work that you're doing with new drug development is really leading us to truly having much better outcomes for our patients than what we previously experienced?
Yeah, so the world of precision medicine has changed a lot in the past 10 years. And I think about, even I just graduated medical school in 2013, which in the grand scheme of things is relatively recently. And even if I think about, what did I learn in medical school? I think that we had like maybe a lecture with maybe a slide talking about NGS and really what's available out there and the extent to which it is used has grown exponentially since 2013, when NGS was just this sort of fledgling new thing. There are targeted therapies that are coming out, new targeted therapies that are coming out. It seems like sometimes every day, but at least every month or so, we seem to be seeing new things come to the market. And yes, there are many tumor types where patients seem to be doing much better or having longer survival when we can target a therapy. Now, I will say that, and Adam is a pharmacist and can actually probably talk about this more than I can, but many of these therapies do come with significant side effects, and there's a lot to consider when you decide to use one of them. There's always a question of quality of life and length of life and what's most important. So there are often really big questions to answer with their use, but sort of in a big picture way, what we can do now compared to what we could do, say, in 2012, very different, very, very different.
Yep, absolutely. Thank you. And I certainly agree. While we do have new great drugs that are coming out, what seems like every day, especially every month, really patient education, such as what this program provides, is so important to ensure that the patient is involved, just as much in the decision-making process to understand the side effects, like you mentioned, how it may affect their quality of life, but also how it really may prolong their life as compared to what we've been used to in the past. So thank you for that. We've got a few questions rolling in, so I'll just hit this one. So why would you get more than one next generation testing?
Oh, that is such a great question. So often you'll have your first NGS test either at diagnosis or at progression with treatment. And So sometimes what happens is that a tumor has, say, a particular mutation that's driving it, that's really making it grow. And then maybe we target that mutation and the tumor sits for a while and behaves itself for a while, and then it starts growing again. Well, then the question is, why is it growing again? Has something else mutated? Has something else changed about the tumor to get it to bump over the treatment that we're giving? And that's usually the question that we're trying to answer when we retest is what's changed, and is the change something that we can target, or sometimes the change is something to tell us, specifically, the drug that you're using isn't going to work anymore. There are certain types of mutations that tell us, this is futile, in which case it's good to stop because you have these side effects that just aren't worth having.
Absolutely. And you mentioned in your presentation that you don't just have to do a tissue sample to be able to run next generation sequencing. There's other maybe more easily obtained samples such as blood that you can do as well. So very important to remember that. The next question that I see is, can you share your thoughts on using CEA as a biomarker, and particularly as it pertains to prostate cancer that has become treatment resistant?
Sorry, I missed the marker that you said. What was that?
Sure, it's CEA.
Oh, CEA. And you said for prostate cancer?
Specifically for prostate cancer that has become treatment resistant.
That's an interesting question. I don't know. I actually haven't come across CEA being used in treatment resistant prostate cancer. That doesn't mean that it isn't used. That just isn't something that I am familiar with. I'm sorry, I can't answer that question. Might be a good question for an oncologist.
Could you extrapolate that to CEA for other types of cancer or disease sites?
Yeah, sure. I mean, so I think of CEA as being sort of like PSA with certain types of cancer, which we talked about, right? So maybe at diagnosis, so, you show up, you're not feeling well, you have stomach pain. The ER doctor, whoever it is that you're seeing, does a whole battery of tests. One of them is CEA, and the CEA is through the roof. And the ER doctor goes, gosh, that may be cancer. And so you have a CT, whatever, you find the tumor. Initial treatment is started, maybe the tumor is cut out, and then the CEA drops, or maybe the tumor can't be cut out and you have chemotherapy, and you sort of watch the CEA hopefully trickle down a little bit with chemotherapy. Maybe it stays down for a while, and then at some point starts to progress again, which means, oh gosh, maybe we need to take another picture, maybe we need to do another CT, see what's going on. Maybe we need to do some NGS, figure out if there's been some sort of change with the tumor. It just gives you an idea of how the cancer is behaving.
Not seeing any other questions. Let's see, just one more. Let's see, how long is a soft tissue sample good for? Is it literally stored somewhere?
Oh, that's a really good question as well. So it depends on how it's stored. So a lot of the tissue samples that we get, if we get them fresh, meaning they were just cut out and put in a jar, they don't last very long. And we try to get to those within, 24, 48 hours. They're put in the refrigerator, they last longer. But a lot of them that we get, if they're going to have to sit for a minute, travel or whatever, then we put them in a substance called formalin, and the formalin hardens them up and keeps them for longer. And usually in pathology, we hold on to samples for a certain amount of time, usually about a month. So if we need to go back to that original sample, it's sitting in formalin preserved in the lab. And then after about a month, it gets thrown out. But then we still have whatever is in those paraffin embedded blocks, and those basically last forever.
Thank you. Got some more coming in here. So can germline testing on a child help determine a parent's likelihood of cancer? That's a great question.
Oh, goodness. Yes. Yes. There are ethical issues with that, though. Yes. So if you have a child who has cancer, it is certainly often worthwhile, depending on the tumor type, to do genetic testing of the tumor, sort of in the same way that you would do as an adult. And there are certain changes that you may find in a child that could have implications for a parent, in which case, it's totally reasonable to test the parent. Now, testing a child just to test a child for germline changes is not always considered ethical, because you usually want a child to understand what they're finding out, right? It's like, can a child be tested for Huntington's disease, this really devastating neurological diagnosis that, means that you're probably not going to have a long life? Some children, is a child really old enough to understand the implications of such things? And testing a child for especially a tumor marker that, for a type of cancer that maybe most often happens in the 30s or 40s, really there's a good argument to wait until adulthood, until that child can make an informed decision about the testing that they want. But in the context of a child having a cancer and testing it and maybe finding something, yes, it can give you a hint about what's going on with the parent as well. And it may be worthwhile to test a parent depending on what you find.
Great. Yeah, and then just to add to that, you might be able to speak to how closely these molecular tumor boards work with genetic specialists and actually involve geneticists to help us make those decisions as well.
Yes.
Let's see. Another question is, are there any specific factors that make someone a better candidate for biomarker testing?
Yeah, there are. So this can get kind of complicated, but ultimately the question is goals of care, right? So if a patient has a particular tumor type where there's really good therapy that is not targeted therapy to start with, and maybe the tumor is not very advanced, there's sometimes not really a great reason to do genetic testing, because you already have great care options without, whatever targeted therapies might come out of your additional testing. And then there's also a point where, maybe a patient is just sort of done with it all. And, that happens at some point, that happens. At which point, why? Why would you do it? And if you're not healthy enough to take, whatever targeted options there are, or if you don't want additional therapy, a lot of this has to do with what a patient wants out of their care toward the end and what is available toward the beginning. Oh, sorry, I should also add, and also tumor types. So there are certain tumor types where genetic testing is a lot more helpful in sort of the question of what next than others. And I imagine that it will become more common for more tumor types as time goes on. But the tumor type does matter.
Yeah, absolutely. Lung cancers and non-small cell lung cancer is a really great example of that. And it's truly taught us so much about biomarker testing over the last few years. So very exciting. Another question that goes back to CEA. This is a popular topic. So CEA, how long does it take to respond after radiation or chemo treatment typically?
It depends on your tumor. So it's really variable from person to person. And, you want to see it go down faster rather than slower. But as far as exactly how fast it happens, I don't, off the top of my head, I don't know what the half-life of it is. I'm not sure how long it lasts. If you blast out half the tumor, should it go down, in a week or two? I'm not really sure. Again, that's probably a better question for an oncologist who follows these things more closely. But ultimately the goal is for it to go down over time and have patience.
Let's see, one more question rolling in, and then we'll probably wrap up here. Is there a sample type that is more informative, a tissue sample or a blood sample?
Oh, that's a really great question too. And the truth is you can get valuable information from both, and the information that you get won't always be the same, interestingly. So you could actually, in someone with metastatic disease in particular, you could take a piece of tissue, let's say from the colon, where maybe a colon cancer started, from the liver, where maybe there's metastatic disease, and from the blood, and you could get different mutations sometimes in all three. Now, often they'll have some overlap, like maybe the driver mutation is the same for all of them, but they won't always look exactly alike. There's an argument that sometimes blood can be better because it's testing the most aggressive part of the tumor, right? It's the part of the tumor that's trying to get out, right? And then there's also an argument that maybe tissue is better because you can get more concentrated tumor and you can test more. So this is an ongoing argument in pathology and among oncologists and a lot of really smart people that I don't think there's a really great, perfect answer to. Probably the answer for now is it depends, which I realize is not very satisfying, but is the answer.
Absolutely. All right. Well, we'll toss it back to Katie to help us wrap up here. And I just want to say thank you again for everybody and everyone's participation.
Thank you, Dr. Bynum and Adam, for such an informative program, such an interesting topic. Sounds like there's a lot to get into with this. Thank you, everybody. If you want to continue the conversation with Dr. Bordoni next week, please visit our website, cscatlanta.org, where you can register for that program. It'll be Frankly Speaking about precision medicine. And again, if you know anybody who missed the live version of today's program, or if you want to reference anything, you can also visit the video tab of our website where we'll have a recording up. So as we wrap up, I'm going to throw it back out to you, Adam and Dr. Bynum, to share any closing remarks. Adam, do you want to go first?
Certainly. Thank you again. So this is such an amazing topic. It really is, changing the way that we see cancer and how we are able to treat patients, what is allowing us to go into research and design of clinical trials. It truly is groundbreaking. And I just have to reiterate what Dr. Bynum said about how involved everybody is on these teams in the hospitals and in the clinics to ensure that your families and yourselves, whoever may be suffering with a cancer diagnosis, is truly getting the best options laid out to them and treatment options available. So again, thank you. And Dr. Bynum, I'll let you wrap it up.
Sure. So, there are a lot of different types of people here, clinicians and patients, and perhaps people who love patients with cancer. And I know that we're all sort of in a different place in perhaps that cancer journey or how we're approaching it. And however long you've been here in this sort of world of cancer, just know that things change quickly. So ask lots and lots of questions every step of the way. And again, just know that there's a whole army of people in this hospital and in the world of medicine who care a lot that you get exactly what you want out of life.
Thank you both for being so generous with your time and expertise today. And thank you, everybody, for joining us and for sharing such good questions. We hope to see you guys soon. Take care. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.